Good morning, everyone. It's my pleasure to welcome you all to Ceylon College of Physicians Specialty Update for month of August. That is on gastroenterology. We are doing this in collaboration with Sri Lanka Society for Gastroenterology, and I'm thankful for the society members for collaborating with us and coming doing this presentation today. And to start off the proceedings, I would like to invite our first speaker, Professor Madhunil A. Niriyalla. He is MBBS, MD, MRCP, FRCP, FCCP, AGAF. He's a professor in gastroenterology, Faculty of Medicine, University of Kelaniya, Ragama, and honorary consultant gastroenterologist at North Colombo Teaching Hospital. He is an academic researcher with interest in clinical research in the field of gastroenterology and hepatology. He has won many awards related to his research and nationally and internationally. So he'll be talking to us on what's new in management of advanced chronic liver disease. So thank you very much, Professor Niriyalla, for being here, and over to you.
Thank you, Chairperson. I'd like to thank CCP and SLHG for the kind invite. My topic is management of decompensated advanced chronic liver disease. I will highlight what's new in the talk because this is primarily the audience is, I believe, is trainees, so I will go through the basics and highlight what's new. I have no relevant conflicts of interest. So in the next probably 25 minutes, I'll try to highlight what's new in the terminology and touch upon the natural history of advanced chronic liver disease, the pathophysiology of the complications, and management of some of the common complications, namely ascites, SBP, HRS, variceal bleeding, encephalopathy, and also talk about some neglected issues like sarcopenia and frailty, and also talk about albumin as a disease-modifying agent. So the terms for cirrhosis has changed because now there is non-invasive imaging such as the fibroscan, which can diagnose cirrhosis very accurately. So in the setting of this non-invasive liver stiffness measurement, the terminology of cirrhosis is eroding away and it is being replaced by what is called advanced chronic liver disease. So we have chronic liver disease, which is any liver disease that is persisting for more than 6 months, and it will become compensated advanced chronic liver disease when the liver stiffness measurement exceeds 15 kilopascals. And at this stage, it is equivalent to what was earlier termed as compensated cirrhosis, where the patients will not have any major symptoms or signs. They will basically be normal, but will have a fibrotic liver. And there are two stages in compensated advanced chronic liver disease, those with clinically significant portal hypertension and those without. And without clinically significant portal hypertension, these patients do quite well. Their annual mortality is about 1%. When they develop clinically significant portal hypertension or they have varices, still the annual mortality rate is around 4%. So these patients do quite well and the average survival is about 12 years. When the patients begin to develop ascites, encephalopathy and GI bleeding, they have advanced stage disease, and this is called decompensated advanced chronic liver disease. Unfortunately, about 40% of our patients present at this stage, and the survival is quite dismal. It's similar to something like cancer at this stage, with an average survival about 1.5 years. So this is the stage where these patients will require liver transplantation. And today's topic will be mainly concentrated for the complications related to decompensated advanced chronic liver disease. So if we look at the pathophysiology of the cirrhosis complications, there is liver dysfunction and there is portal hypertension, and this will result in various ways to increased tendency towards bacterial infections, renal dysfunction, formation of ascites, hepatic encephalopathy and variceal bleeding. Let's take the first complication, ascites. So I told that once ascites develops, the annual mortality rate jumps to about 20%. So there is a high 1-year mortality. All patients who are admitted non-electively should have a diagnostic paracentesis. It is very important because we need to exclude the presence of any significant infection in these patients. And when we do paracentesis, we look at basically the cell count, more than 500 white cell and more than 50% of that, that's 250 polymorphs per ml, is suggestive of spontaneous bacterial peritonitis. Once ascites develop in your patients, you know that the mortality is high and these patients qualify for liver transplant, and they should be referred for evaluation for liver transplantation. How do we manage these patients? The grade 1 ascites, usually only detected on imaging, can be managed easily with salt restriction, sodium less than 2 or salt less than 6 grams. We do not go beyond that. We do not overtly sort of overdo this salt restriction, because now we know that the more we try to restrict the salt, the palatability goes down and the patient's caloric intake is at risk. So nutritional depletion is a risk. So we only sort of restrict the sodium in the initial stages, and we try to sort of tell the patients to gradually sort of take salt in lesser amounts. So grade 1 ascites, what is needed only is salt restriction. Then grade 2, where there is clinical ascites, we need diuretic therapy. The traditional teaching was that to start with a aldosterone antagonist like spironolactone and then add on furosemide, but now from studies we know that rather than sequential from spironolactone to furosemide, combining the diuretics together, there will be more rapid mobilization or resolution of ascites and lesser side effects. So now what we do is actually we start off with both spironolactone and furosemide at the same time. When we have grade 3 ascites, we need to do large volume paracentesis when the ascites is very large and tense and the patient is in respiratory distress, or when patients are diuretic resistant or intolerant. We remove up to 5 liters or more than 5 liters in 24 hours is the definition for an LVP. And if we do this, we have to prevent what's called a PPCD or post-paracentesis circulatory dysfunction by giving volume expansion, and the volume expansion of choice is albumin. We replace in excess of each 5 liter. If we remove 6 liters, we have removed excess of 1 liter. For that, we replace about 8 grams of albumin. If there is renal impairment, irrespective of the volume removed, we have to replace albumin for each liter that is removed. So that is something new. So earlier the teaching was in excess of 5 liters, each liter should be replaced with 8 grams. But when there is renal impairment, you have to replace albumin for each liter. Okay. So when we can't manage with only LVP, we have to consider tips carefully. The patient should be selected, because although there is good control of ascites, there is an increased risk of encephalopathy, and some studies have shown slight survival benefit if we choose the patients very carefully. So now there is good evidence that prophylactic rifaximin before the tips and under dilation and controlled expansion of the tips, we can sort of use tips in patients who were earlier deemed sort of unsuitable for tips. The problem of tips nowadays is that we probably don't have the radiological expertise or don't have the funds to purchase these tips through the state sector. So this is almost a non-existent therapy in the current setting. Those patients who, for completion, I'll just mention that those patients who cannot be managed with tips, there is another option called an alpha pump, which drains the ascites and it is excreted via the urinary system. There is a diagram there. This pump is helpful to reduce symptoms in very refractory patients, alpha pump. So these are some of the do's and don'ts. So restrict salt up to 2 grams, restrict sodium, for up to 2 grams. Give a combination of aldactone to Lasix 5:2, a combination from the start. Assess the response and tolerance. Monitoring weight is very useful way to assess the response and look at the potassium. Don't use LVP unnecessary. It is only for tense ascites. We have to avoid some drugs like NSAIDs. Don't overdiuresis. Don't underdose. TIPS is not the first line. It is only for very selected patients. Gynecomastia can be a problem, and we can substitute spironolactone to amyloid 10:1 and spironolactone to eplerenone 2:1. If there is severe hypoalbuminemia, albumin infusions can be helpful. If there is hypotension, midodrine can be useful. If there is diuretic resistance, that means going up to the maximum dose of diuretics, 400 of spironolactone and 160 of fusamides. If still we can't mobilize, or if the diuretic intolerant ascites is there, where the patient has severe hypotension or intractable cramps, or develops AKI or electrolyte imbalances, where we can't go up, we can't step up the diuretics, that is called diuretic intolerant ascites, we can use TIPS. Coming to SBP, again, very high hospital mortality and very high recurrence within 1 year. And this is an indication for, again, liver transplant evaluation once a patient has an SBP, and that's a very significant prognostic event. This is a frequent precipitant of acute and chronic liver failure, and there should be a very high index of suspicion because abdominal pain and fever may not be there in most of these patients. I have talked about the paracentesis. Just want to mention that if there is a traumatic TAP, the correction is 1 polymorph for 250 red cells. So if there is like 1000 red cells per ml, you reduce 4 polymorphs from the polymorph count. You need to send off cultures, and what we usually get is culture negative neutrocytic ascites. The neutrophil more than 250 is not SBP. It is culture positivity that defines SBP, but this neutrocytic ascites is as good as having a culture. So most of the time cultures are negative because these patients are given antibiotics in the community. Then we also have an entity where we have non-neutrocytic bactericidis. That means the counts are less than 250, but the initial culture is positive. So what we do in that instance is go by the patient's other features, abdominal pain, fever, and we can repeat the count and see in about 24 hours to see if the count is rising, and then we treat as a standard SBP. Timing of paracentesis is very important. The earlier you do it within 12 hours of admission, better. Delay in the paracentesis is associated with increased mortality. So what is the antibiotic? In community acquired SBP, it's usually a third generation cephalosporin like ceftriaxone. For hospital acquired SBP, consider something like meropenem. Duration is minimum IV 5 days, as good as 10 days. And we tend to do the paracentesis after 48 hours in selected patients. Some of the guidelines say that we have to do the paracentesis routinely after starting antibiotics to compare with the baseline at 48 hours. What we do is we do for the sicker patients who have very initial high counts to see whether there is a 25% drop at 48 hours, which is a good response. We would hold the beta blockers if the patient has HRS at this time. We would avoid PPIs, and we might optimize the volume. Certain patients will need prophylaxis. Obviously, when you have one episode, the recurrence rate after 1 year is 70%, so you need to have secondary prophylaxis, usually with norfloxacin or ciprofloxacin, and Cotrim also can be used. In upper GI bleeding, you know that you have to give the antibiotics to prevent SBP, and sometimes we give primary prophylaxis, especially if the acidic fluid protein is very low, coupled with high CTP score and renal insufficiency, even in the absence of an SBP. Coming to hepatorenal syndrome, again, an event that is associated with high mortality. The terminology definitions have changed. An AKI is defined by a 0.5 rise, 0.3 milligram per deciliter rise within 48 hours, or more than 50% rise from the baseline within 7 days. And the baseline is taken as the most recent value of serum creatinine when the patient was ambulant within 3 months. So when there is AKI, you have either HRS AKI or HRS non-AKI. HRS AKI is where there is AKI plus a patient with cirrhosis and ascites, and there is no response to volume expansion after 48 hours to exclude any prerenal component, where we give IV fluids plus albumin 1 milligram per kilogram for 2 days, and there should be no medication, shock, significant protein hematuria, or damaged kidneys on ultrasound to diagnose HRS. Non-HRS AKI can be HRS CKD or AKD depending on the duration of the renal impairment, which is less than 3 months and more than 3 months. How do we treat? The mainstay of treatment is volume expansion and vasoconstriction. We have terlipressin and norepinephrine. Both are probably equally effective. Terlipressin may be a little bit more effective in this setting. Midodrine and octreotide can be used, but is less favored. Albumin should be given regardless of the vasoconstrictor used. About 40 grams of albumin, 20% albumin for a day. Treatment, this combination of the vasoconstrictor plus albumin can be given up to about 14 days, where if there is no improvement, probably patient is not going to get better, and we have to think of renal replacement therapy in these patients. So how do we prevent HRS? I have told that one thing, at times of LBP, large volume paracentesis, we have to replace the albumin. In the setting of SBP, again, we give albumin on day 1, 1.5 grams per kilogram, and day 3, 1 gram per kilogram, and that will prevent these SBP patients from going into HRS. Also avoid NSAIDs. NSAIDs are very bad in patients with decompensated advanced chronic liver disease. It should be avoided. Even a single tablet of Voltaren or ibuprofen can push these patients into quite severe renal failure and upper GI bleeding. So we tend to avoid NSAIDs in decompensated cirrhosis. The sicker patients, who are in the ICU, we tend to maintain volume status, and the mean arterial pressure target is probably around 65 for the most sicker patients to prevent AKI. So here is an algorithm. When patients are hospitalized with cirrhosis and AKI, if they fulfill the HRS criteria, we volume expand and give albumin. If there is improvement, that's a prerenal azotemia. If there is no improvement, if all criteria are met, we treat as for HRS with albumin and vasoconstrictors. If they don't meet the HRS criteria, then it's an ATN. What about variceal bleeding? Again, high incidence and high mortality. Higher mortality related to higher CTP score. Increased bleeding risk as well. The risk factors for bleeding is decompensated state, prior history of bleeding, coagulopathy thrombocytopenia, large varices versus small, and the presence of red signs on endoscopy. Pre-endoscopy, certain things help patients improve survival. Octreotide or terlipressin can be given as a vasoconstrictor to reduce the portal pressure. Both are equally effective. If you give octreotide, probably there is no need to give any PPI at all. Antibiotics are important because the antibiotic can be a precipitant, and the bleed can predispose to gram-negative septicemia through bacterial translocation. So give Ceftriaxone 1 gram BD, a total of 7 days. We don't transfuse these patients overtly. We aim for a target of 7 to 8 hemoglobin in these patients. That is more than enough. So we adopt a restrictive blood transfusion policy. PPI infusions are not very useful. Even in the setting of ulcer bleeding, there is no mortality benefit. As I told you, if you are giving octreotide, don't give PPI because there is no need, because the octreotide will suppress the acid. So endoscopy timing, usually these patients should be scoped within 12 hours of presentation. That's the standard of care. Tips can be used as salvage when endoscopy fails, or in more recent studies have shown that the sicker patients who have more advanced liver disease, preemptive tips even before endoscopy may have a survival advantage. But of course, then you have to have cross-sectional imaging to exclude portal vein thrombosis and HCC, and you need a good echocardiogram to exclude right heart involvement. Post endoscopy, we do I have seen most patients who have had variceal bleeds, who have undergone banding, who never come back for endoscopy. So that's wrong. They need continuous endoscopic surveillance 2 to 4 weeks after banding till varices are eradicated. We tend to band these patients repeatedly and get rid of all the varices, and then only we can stop the surveillance and get on with 1 yearly surveillance. Beta blockers should be given to all patients who have had bleeding, because the standard of care is EVL plus beta blockers. We have 3 options: nadolol, propranolol, and carvedilol. Carvedilol is slightly better in improving outcomes because it not only has alpha blockage, it also has not only has beta blockage that dilates the splanchnic circulation, reduce the portal inflow. It also dilates the hepatic sinusoids through an alpha blockage and causing increased outflow. So carvedilol has beta blockage, which causes splanchnic inflow reduction, and it also has alpha blockage, which causes sinusoidal dilatation and outflow increase. So it reduces the portal hypertension slightly more than propranolol. We can only titrate the beta blocker to maximum tolerated doses, and that is usually by inducing a bradycardia about 55 to 60 beats per minute heart rate, provided that the systolic blood pressure is maintained and the patient is not symptomatically hypotensive. Remember that we don't use the high doses that the cardiologists are using, because carvedilol is liver metabolized and we only have to give low doses, and the maximum dose is 12.5 grams in divided for a day. So usually most of our patients will be on 6.25 BD. A little bit more about beta blocker. There is no primordial prophylaxis. When there is no varices, there is no need for beta blockers. But once there are varices, if you see even small varices on endoscopy, please start carvedilol for these patients, because giving full dose carvedilol in the stage of compensated cirrhosis with varices will delay the onset of decompensation. This is something new. So if your patient is sent for endoscopy and the patient has small varices, it's a compensated cirrhosis patient, please start the carvedilol, because that will prevent the patient from decompensating. It will delay the onset of decompensation. So beta blockers are very useful in these patients with compensated cirrhosis. You will see most of the hepatologists giving beta blockers to these patients at an early stage. Once there is ascites, we tend to use a reduced dose of beta blocker, but you can safely give it as long as the blood pressure is maintained, sodium is high, and there is no AKI. Once the patient has varices and ascites and is hypotensive and has hyponatremia and AKI, we do not continue the beta blocker. We hold it temporarily because it can increase mortality. So these patients will invariably be banded. Coming to the last complication that I want to talk about is hepatic encephalopathy. And once hepatic encephalopathy develops, the 1 year mortality rate jumps up to about 57%. So this is a very bad prognostic feature in a patient with cirrhosis. The consequences are falls, accidents, increased hospitalization, mortality, and a lot of burden to the patient as well as the caregivers. Variable presentation, you know that there is the West Haven criteria. Grade 0 is minimal hepatic encephalopathy. Grade 1 is just lack of awareness and reduced attention span. Grade 2, where the patients have flaps and will have sort of disorientation. Grade 3 will be confusion. Grade 4 will be coma. And the usual precipitants should be very carefully looked at. Usually it's an infection. It can be GI bleed, diuretic overdose, electrolyte imbalance, constipation, continued alcohol, malnutrition, and post-tips. Treatment, something new with regards to hepatic encephalopathy is that in overt episodes in your cirrhotic patients, patients who present with hepatic encephalopathy, please hydrate these patients with balanced solution like Hartmann's. Just hydration, just like when patients present with hyperglycemia, we tend to hydrate patients. Hyperammonemia and other nitrogenous phase also needs hydration to get the ammonia levels down. So hydrate these patients. Give lactulose because it's very helpful to maintain 2 to 3 bowel motions for a day. Studies have shown that actually more than the bowel motions, it is the stool consistency that is more important. So if you go by the stool consistency, it's the Bristol stool scale 6 or 7, very loose stools that you are aiming for. You can, if the lactulose is not working, you can use enemas, phosphate enemas, or polyethylene glycol containing laxatives. Give rifaximin, it's helpful. Zinc supplementation and IV LOLA, branch chain amino acids, have limited data, but in some patients it's useful. Please do not restrict protein in these patients at the acute setting or long term, because it's only going to be detrimental, because by restricting proteins you're only going to cause sarcopenia, and sarcopenia is going to worsen the patient's encephalopathy with recurrent episodes. You need muscle for protection against hepatic encephalopathy. So even in the acute stage, give them normal protein diet, don't restrict. Okay, I think we have gone through this. One thing is that nutrition is very neglected in these patients. These patients should have adequate calories, around 35 kilocalories for a day, and about 1 to 1.5 grams of protein, just to maintain the nutrition to keep them out of encephalopathy. Some neglected issues I'd like to talk about: sarcopenia and frailty. Sarcopenia is due to multifactorial reasons: inadequate calorie intake, inadequate uptake of nutrients, excessive catabolism, and so on. This leads to frailty. Frailty is a term that is not specific to cirrhosis. It is just that the patient has reduced physiological capacity to sustain additional stressors. So there is reduced physiological capacity in this patient, and this will lead to increased decompensation, more hospital admissions, reduced quality of life, death, and adverse post-transplant events. So we don't want sarcopenia and frailty in our patients. What do? We assess these patients very carefully, clinically, physical examination, and objective measures. Something very useful would be a hand grip strength assessment. That's very useful, can be easily done in the clinic. In the post-COVID era, we can again get back to shaking our patients' hands and asking the patients to grip our hand. These patients with sarcopenia and frailty, they are unable to grip your hand, and it's a very poor marker. And we have some other objective tests. I would suggest you go and read about this: a 6-minute walk test and 4-meter gait speed, and so on. The liver frailty index. These are very useful screening tests for sarcopenia and frailty. What do? Actually, we have to attend to nutritional therapy, intensive nutritional therapy with adequate calories, macronutrients, proteins. We also give branch chain amino acids. We encourage physical activity, resistance training. We sometimes selectively give hormonal therapy for patients, testosterone for men, and we also have sort of microbiota related therapies. I have highlighted the importance of adequate protein intake in preventing malnutrition and the adequate calories. So frequent small meals, what we actually tell our patients, either have the 3 main meals but also have a snack in between and a late evening snack before bed. It's very important to maintain and reduce the fasting time in cirrhotic patients to reduce the catabolism. So at least a glass of milk at night before bed. So albumin is coming up as a disease-modifying agent. There are 2 trials. The ANSWER trial looked at very stable patients with ascites, giving them albumin for twice a week for 18 months, outcome was okay. When you looked at more sicker patients in the entire trial, who were inpatients, whose albumin was tried to maintain above 3 with albumin infusions, the outcome was poor. So albumin has a place for patients who are stable outpatient cirrhotics who have ascites. If you get them and give albumin twice weekly, their survival will improve. Problem is the cost. Don't give albumin to the sicker patients who are inpatients. That will only increase the pulmonary edema and increase mortality. So there are some patient-reported symptoms that are very important. For muscle cramps, what do? We can use vitamin E, taurine. We can use hydroxychloroquine and baclofen. For pruritus, cholestyramine is very useful, and so is naltrexone. Sleep disorders, melatonin is very useful in the early stage, and hydroxyzine can be used. So sexual dysfunction, we can use something like sildenafil equivalent drugs like tadalafil. Last but not least, always emphasize on patient education. They should understand the importance of following the treatment plan and avoiding alcohol and substance abuse. Alcohol avoidance, extremely important in patients who have had a history of unsafe alcohol use. Patients' quality of life is our priority actually. We have to improve the quality of life and the overall well-being. Get the family and the caregivers involved in the care plan, and be very helpful. You can teach them to sort of titrate the diuretics, give a course of antibiotics if there is suspicion of infection, so that we start antibiotics early, so the patient can be kept out of hospital. And always emphasize the need for liver transplantation at the correct time, when the patient is not very sick, when they have ascites, when they have encephalopathy, when they are child's B, when the MELD is 15, please refer to a liver transplantation unit, at least to see whether transplantation is a feasible option for these patients. I have run out of my time. I think I have mentioned everything that I wanted to say. Thank you.
Thank you, Madhunil, for that excellent look into the cirrhosis and its advances and newer guidelines. Just a few questions will be there. Yeah. Anybody from the audience, physical audience, wants to raise any questions? Yeah. There's one, again, just a clarification on the virtual audience. Again, they want to highlight whether the change of this spironolactone and furosemide been used together. So that's they just want to check on the new guideline.
Yeah, that is the recommendation actually. We don't sequentially go from spironolactone to furosemide. Earlier it was 50 spironolactone, 100. Once you exceed 100 only, we would have gone to 40 of furosemide. But now it's both together.
Okay. And the question on place of terlipressin on variceal bleeding.
Yeah, terlipressin is sort of the drug of choice. If you have it, give terlipressin up to a maximum dose of 12 milligrams for 24 hours. So we start with 1 milligram per 6 hourly. We can go up to about 2 milligrams 4 hourly if the patient is bleeding. But I must say that octreotide in trials is as useful and as effective. So both are equally effective, terlipressin and octreotide. Octreotide you have to give it as an infusion. Terlipressin you can give it as boluses.
One more question. Can we start beta blocker with CSPH without varices?
Okay, that's an interesting.
Based on a trial, I think.
That's an interesting question. So at the moment, what we define by clinically significant portal hypertension is portal pressure more than 10 milligrams per 10 milligrams mercury. So that is in ideal setting measured by what is called a hepatic venous pressure gradient, that is a catheter measurement. So that is not feasible in our patients. So we have an indirect measure, which is the liver stiffness and the platelets. So we go by the liver stiffness and platelet measurement to define clinically significant portal hypertension in our patients. So the current cutoffs is when you have stiffness of more than 25, when the liver stiffness measurement or LSM is more than 25, there is a very high probability that the patient has CSPH or clinically significant portal hypertension. This still can be true if the stiffness is more than 20, and you must have the second criteria, platelets of less than 150. So these patients, although we predict the likelihood of portal hypertension, we still do an endoscopy and demonstrate varices and then only start. For I think the question is whether to start beta blockers for varices that are detected on cross-sectional imaging. I think that is what probably the audience is asking. So in the setting where you detect, so endoscopy, no varices, cross-sectional imaging shows varices, probably starting beta blockers will still be beneficial for these patients. So any feature of clinically significant portal hypertension in a compensated cirrhotic patient, either criteria based on LSM or endoscopy or cross-sectional imaging, if you can predict varices or see varices, please, yes, do start beta blockers if there is no contraindication.
Stopping beta blockers, even sodium less than 130 alone, should be, less than 130 alone, should we stop beta blockers?
130 is the usual cutoff. 125, some guidelines say, because the 125 is the cutoff for sodium where we start intervening to correct the sodium. In a cirrhotic patient, if you see a sodium of 132, 128, we are not really bothered because that is expected in a patient. But once it comes below 125, we start restricting the fluids. So 125 is more reasonable, but some of the guidelines say 130 because hyponatremia, in the presence of hyponatremia, beta blockers have shown to increase mortality. So you should temporarily at least withhold, especially in the setting of hypotension as well and renal impairment.
Yeah, one last question. Any substitute for rifaximin if it's not available?
No, unfortunately there is no substitute.
Right. Thank you very much, Professor Nerialla, for that wonderful lecture and discussion. Thank you. Our next speaker is Dr. Hasita Vijayawantha, Ceylon College of Physicians Council member, and who has very thankful to him for organizing or coordinating this event. He is MBBS, MD, MRCP, graduate of Faculty of Medicine, University of Colombo, and MD in 2014. Currently, he serves as the consultant gastroenterologist at the teaching hospital Ratnapura. He'll be speaking to us on diagnostic approach for patient with chronic diarrhea. Over to you, Hasita.
Thank you, sir, for that kind introduction. And I must thank Ceylon College of Physicians for giving us this opportunity to present the specialty update in gastroenterology. So my topic is chronic diarrhea, diagnostic approach. So, doesn't move. Slides doesn't move. Yeah. Okay. Right. So over next 25 minutes or so, I will be talking on these topics: introduction and definitions, initial assessment, red flags in chronic diarrhea, causes of chronic diarrhea, and secondary assessment, and take-home messages. Right. Okay, chronic diarrhea is a common manifestation. It's a leading cause of healthcare utilization. Roughly about 10% of consultations of a gastroenterologist is due to diarrheal diseases. So it can be a symptom of many diseases, and there is no one optimum strategy to investigate diarrhea. And it has a broad range of etiologies, and it's extremely difficult to propose a specific diagnostic pathway. So diagnostic approach may vary depending on the likelihood of a specific diagnosis. For example, if when a patient presents to you, young man with abdominal bloating, abdominal bloating and frequent stool passage without any other comorbidities, we are not bothered much, and we might give a trial of therapy and see before going into invasive investigations. Whereas if the patient is an elderly man with history of bleeding PR and weight loss, then we might investigate more intensively and rapidly. So basically, the diagnostic approach would vary depending on the likelihood of a specific diagnosis and availability of the treatment, severity of symptoms, and of course the patient preference and comorbidities. And specific diagnosis can be achieved in more than 90% of patients with chronic diarrhea. Diarrhea is one condition where doctor's perspective and the patient's perspective may be different, right? Patient may call diarrhea for loose consistency, simple increased frequency, urgency of bowel movements, and even for incontinence. Whereas we doctors tend to be more specific and objective, and then we call diarrhea when there is more than 3 liquid stools per day and the stool weight is more than 200 grams or 200 milliliters per day, and stool consistency of type 5 to 7 on Bristol stool chart. However, now this stool weighing business, no one, as you would have experienced, none of us do it in the practice, and also now latest studies have found that it's not a reliable method of diagnosing diarrhea, because if you are on a high fiber diet, even with normal amount of stools, you can have a stool weight of more than 200 grams. So therefore, their later definition, the stool weight has been omitted. Now let me explain to you a bit about the Bristol stool scale. This was proposed by a group of gastroenterologists in Bristol Royal Infirmary. That's why it's called Bristol stool scale. And the diagram is self-explanatory, and type 1 to 2 stools are constipated stools, 3 to 5 are normal, and 5, 6 and 7 are diarrheal stools. And then this, now considering all this, the recent guidelines issued by British Society of Gastroenterology propose this definition for chronic diarrhea: persistent alteration of stool consistency from the norm with loose stools type 5 to 7 on Bristol stool chart, and increased stool frequency of greater than 3 loose stools per day for at least of 4 weeks duration. So the highlights are, there should be an alteration from the norm, and stool consistency should be 5 to 7 on the Bristol stool chart, and there should be greater than 3 loose stools per day, and duration should be at least 4 weeks. So what is pseudodiarrhea? Now, as I explained to you, patient might call it diarrhea even when they are passing the normal stools with increased frequency. So this is called pseudodiarrhea. So the type 3 to 5 on stools on Bristol stool scale, only the increase of frequency is there. So that is called pseudodiarrhea. So then chronic diarrhea, now as I explained to you earlier also, chronic diarrhea is a symptom or sign and not a disease, and it can be caused by numerous conditions. And most importantly, even new onset diarrhea less than 4 weeks duration may reflect serious organic disease. Right? Let's not confine to these definitions. Now investigating a symptom or sign like this has to be more clinically focused and clinically oriented. So that's why I told you earlier, so that our diagnostic approach would depending on the likelihood of a specific etiology. So diagnostic approach, the age-old method, history examination and investigation, there is nothing very technical here. So let's talk about what are the important features in the history. So the onset, congenital diarrheas. Now these are more common in pediatric practice, however they can run into the adult practice as well. For example, cystic fibrosis, Fanconi's anemia, aclohydria, and lactase deficiencies. These are congenital diarrheas, and the onset, abrupt onset diarrhea, gradual, and the pattern of diarrhea, whether continuous, intermittent, and whether the patient has night diarrhea, and the duration. Duration, now if it is recent onset alteration of bowel habits, less than 3 months duration, most of the time it is significant, right? Whereas now if the patient has passage of loose stools for years, then it is less likely to be a sinister pathology. So chronic diarrhea less than 3 months duration most of the time implies a significant pathology, and I mean it doesn't mean always, but then we have to be more concerned. So epidemiology, family history, drug history, all these are familiar to you. And stool characteristics, watery, bloody, fatty stools, and the stool volume. And tenesmus and urgency indicates rectal involvement. So when there is proctitis, the patient tends to have urgency and tenesmus. Incontinence is the sphincter laxity. So abdominal pain, weight loss and appetite. Now weight loss and appetite should be considered together. Now there are conditions which cause weight loss with normal appetite. What are the conditions? That means malabsorption. Now everything is normal, food doesn't get absorbed through the GIT, right? And then weight loss with increased appetite. What are the conditions? Hyperthyroidism, diabetes, right? Weight loss with reduced appetite. All the other infective, neoplastic and inflammatory conditions, right? And then aggravating factors, diet, stress, alcohol, caffeine can cause diarrhea, and osmotic diarrheas can improve, osmotic diarrheas improves with fasting, and mitigating factors like diet, over-the-counter drugs and therapeutic drugs, and the history of previous evaluation is also important. And iatrogenic diarrhea, drugs. Drugs are one of the most important causes of diarrhea, and whole lot of drugs, NSAIDs, ACE inhibitors, you name it, like most of antibiotics can cause diarrhea. And one of the very significant causative agent is Clostridium difficile. And I have seen the prevalence of incidence of Clostridium difficile diarrhea is rising, because we are, with increasing use of antibiotics, we tend to diagnose C. diff infection in the wards more frequently. Consider Clostridium difficile infection if you see a patient with diarrhea after prolonged hospital stay and after receiving multiple courses of broad spectrum antibiotics. Radiation is one other cause for iatrogenic causes, and past history of surgery. Cholecystectomy is one of the causes for chronic diarrhea, because it increases the free pool of circulating bile, free pool of bile acids available in the intrahepatic circulation. So then there will be more bile acids in the colon, which will induce osmotic diarrhea. And extensive bowel resections and bypass, gastric bypass surgery, especially involving blind loops, and ileal resections, that again due to reduced absorption of bile acids. And systemic diseases, you all are familiar with this: diabetes, hypertension, tumor syndromes, HIV, immunoglobulin deficiency, tuberculosis is one of the common things. And then factitious diarrhea, laxative. So then examination, right? So examination can be negative in some of these patients, right? So some of the diarrhea patients, we may not have, even with sinister pathologies, may not have any physical sign. However, some other patients can have a whole lot of physical signs, right? So you are familiar, and I know that most of the audience are trainees, and you all are familiar with these physical signs, and I would like to highlight some of the physical signs, not because they are superior physical signs or more important physical signs, but these are the ones we tend to miss very often. And if we find this, it will make our lives very easier. Now, abdominal masses. If you find an abdominal mass, that means it's a kind of a sinister pathology. And ascites. Presence of ascites would imply that it can't be an isolated intraluminal pathology. The diagnoses like tuberculosis, malignancies come high up in the list. And perianal fistulae and abscesses. So sometimes it would give rise to, it is the main clue for a diagnosis like Crohn's disease, and laxanal sphincter and rectal prolapse. And I have seen patients have been referred for colonoscopy due to chronic diarrhea, and when we try to do the colonoscopy, we find that there is a huge rectal prolapse. So it would have been, would have been diagnosed with the PR examination itself, and fecal loading on DER, especially in patients with neurological disorders and learning disabilities. So examination. So the registrars who are getting ready for the MD part 2. So what's the diagnosis? Episcleritis, right? This is a patient with inflammatory bowel disease. And what's this? Erythema nodosum. Again, inflammatory bowel disease. What's this? Proptosis. And if you look carefully, what's this? It's a goiter, right? Thyrotoxicosis. This is obvious. Angular stomatitis and glossitis. And what's this? If the patient has had anemia, iron deficiency, dermatitis herpetiformis. What's the underlying diagnosis? Celiac disease. And any guesses? Macroglossia, amyloidosis. And what's this? Pyoderma gangrenosum, right? Inflammatory bowel disease, right? So what are the initial investigations? Full blood count. Full blood count is one of the most important investigations in patients with chronic diarrhea. So anemia, iron deficiency, mixed deficiency, which will give rise to the affected part of the small intestine. Iron deficiency means the proximal small bowel, duodenum and the proximal jejunum is affected, right? And then thrombocytosis. Thrombocytosis, platelets is a marker of chronic inflammation, and also platelets goes up with chronic low grade blood loss. So I have seen patients with anemia and thrombocytosis. The reason is worm infestations, chronic low grade blood loss, and also Crohn's disease, tuberculosis can have anemia and thrombocytosis. And then hypoalbuminemia. Albuminemia can be low due to malnutrition, and also it's a reverse inflammatory marker. It's inversely proportionate to the ESR. So in the presence of chronic inflammatory conditions, albumin can be low. And electrolytes, sodium, potassium and calcium. When you do calcium, do albumin also, because in chronic diarrhea patients, calcium has to be corrected to the albumin levels. And raise inflammatory markers, low TSH, stool FR. Stool FR is not a very reliable marker. However, if the patient has large number of red blood cells and WBCs in the stool FR, it implies a significant pathology. And fecal local blood, the diagnostic test is, the preferred method of testing is fecal immunochemical testing. So, and then X-ray abdomen. X-ray abdomen is a very useful investigation. You can see pancreatic calcifications in chronic pancreatitis, and overflow diarrhea, the left-sided fecal constipation and fecal loading will be there in the X-ray abdomen. And thumb printing. Thumb printing means it's a feature of acute colitis. So acute severe colitis, and even in other conditions with inflammatory colitis, thumb printing will be there. And stool microbiological evaluation. So Clostridium difficile is one of the most important tests in this, in inward setting. If the patient has been referred to you in an ICU patient who had received multiple courses of antibiotics with new onset diarrhea lasting for more than 2 to 3 weeks, so always do Clostridium difficile infection and Giardia cryptosporidium in immunocompromised patients. And then after initial evaluation, you have to look for red flags in diarrhea. What are the red flags? Bleeding per rectum and presence of anemia. And unintentional weight loss. As I explained to you earlier also, weight loss can be broadly divided into intentional and unintentional. Intentional weight loss, we are not worried. Unintentional weight loss, as I explained to you, we should be analyzed together with the appetite. So diarrhea, disturbing sleep. It's not passing stools when you are awake. So if you wake up with the need to go to the toilet, that's a sinister symptom. And raised inflammatory markers and associated fever. Onset after 60 years of age, right? Electrolyte imbalances and high volume or stool frequency more than 6 to 10 per day. So these are the red flags. If any of your patients has any of these symptoms, these patients should be further investigated, especially with a lower GI endoscopy or colonoscopy. And then how do we, come to how do you arrive at a diagnosis? How the nature of stools give rise to the etiology. The fatty stools in malabsorption and maldigestion, and watery stools in secretory and osmotic diarrhea. And inflammatory or bloody diarrhea can occur in inflammatory bowel disease and dysentery, especially in colitis, infections, right? And then what are the fecal markers of intestinal inflammation? We discussed about ESR, we discussed about CRP, those are blood markers, hematological markers. And what are the stool markers of intestinal inflammation? The commonest used one, it is listed here, and commonest ones are fecal calprotectin and fecal lactoferrin. And fecal calprotectin specially has been evaluated in differentiating IBD from non-IBD causes. So, it's fecal calprotectin levels is not available in Sri Lanka. I think it's not available in private sector also, isn't it, sir? Right. I think it is not a fecal calprotectin positivity and negativity. We can, it's available in Sri Lanka, but it's not of much use. It's like fecal local blood. However, if you can do fecal calprotectin levels, it gives us the severity, it gives us a lot of information. Now, if the fecal calprotectin level is more than 50 grams per gram of 50 micrograms per gram of stool, it correlates with the endoscopic severity of ulcerative colitis and Crohn's disease. So, Mayo index is a severity index of ulcerative colitis. CDAI means Crohn's disease activity index, and fecal calprotectin levels have a positive correlation with both Mayo index and CDAI. And what are the non-IBD causes? It's a not very specific test. When you know, like if you just do positive and negative, if you get the result as positive and negative. So infections, neoplasms, drugs, inflammatory conditions including IBD, autoimmune enteropathy, cirrhosis, cystic fibrosis, diverticulitis, all these can cause positive fecal calprotectin, right? And other causes, even in some of patients with less than 5 years of age, and untreated food allergy also can give rise to positive fecal calprotectin. So chronic diarrhea, now we have discussed initial and some of the most of the initial evaluation, and what are the causes of diarrhea according to pathophysiology. These are the causes of secretory diarrhea, right? Still laxatives, drugs and toxin, chronic alcohol use, and so you can read this in textbooks. And osmotic causes, osmotic laxatives, disaccharidase deficiencies, presence of non-absorbable carbohydrates in the intestine cause osmotic diarrhea, and malabsorptive and steatorial causes. It could be intraluminal maldigestion, that means there is no digestive enzymes is not there, lack of digestive enzymes. Chronic pancreatitis, bacterial overgrowth, fructose and lactose maldigestion, and malabsorption, that means the disorder is in the absorptive surface. Whipple's disease, infections and celiac disease. And postluminal obstruction, the surface and the enzymes are normal, however there is postluminal, the absorbed the nutrients are not transported properly, primary and secondary lymphatic obstruction. So inflammatory causes, ulcerative colitis, Crohn's and microscopic colitis, osmotic causes, visceral neuropathy, dysmotile causes, visceral neuropathies, diabetes, hypothyroidism and drugs, and other causes GI malignancies, radiation injury, chronic infections and factitious diarrhea, and fecal impaction and overflow also can mimic diarrhea. So especially you have to be watchful for this in elderly patients, patients with learning difficulties, and patients with neurological and spinal diseases. So basically diarrhea can be broadly divided into functional and organic. So functional causes are diarrhea predominant IBS and functional diarrhea, and organic causes inflammatory, infective, osmotic, secretory, endocrine, neoplastic and drugs. So now at this stage it's very important to analyze symptoms and the results of initial investigations to arrive at a diagnosis or narrow down your list of differential diagnosis. And if the patient fulfills the criteria for functional diarrhea or IBS diarrhea, very important to put them on a trial of treatment without further investigating and wasting resources. So what are the diagnostic criteria of irritable bowel syndrome? Recurrent abdominal pain on average at least, this is Rome 4 criteria is the criteria used to diagnose irritable bowel syndrome. It includes recurrent, where the criteria is recurrent abdominal pain on average at least 1 day per week in the last 3 months, associated with 2 or more of the following, related to defecation, associated with change in frequency of stools, associated with a change in form of stools. And abdominal bloating and distension is typically present, and symptom onset should occur at least 6 months before the diagnosis, and symptoms should be present during the last 3 months. So IBS diarrhea, now IBS can be diarrhea predominant, constipation predominant or mixed. So IBS diarrhea is when patient fulfills criteria for IBS and more than 25% of the time has loose stools and less than 25% of the time has hard stools. So if the patient fulfills that criteria, you have to positively diagnose IBS diarrhea and start a trial of treatment. And functional diarrhea is patient has diarrhea but does not fulfill the criteria for IBS. However, the other recurrent passage of loose stools is there, and abdominal pain and bloating are not marked symptoms, and the onset should be more than 6 months ago, and symptoms should be present during the last 3 months. And however, this symptom based criteria are only specific around 75%. Now some trials have shown 52 to 74% specificity. So you can go wrong, right? So always even though you have started a trial of treatment as for IBS or functional diarrhea, always watch out for red flags. And then after initial evaluation, if the patient have features suggestive of a colorectal neoplasm, refer for an early colonoscopy. And then if the patient has severe, persistent or atypical symptoms and signs, or alarming symptoms or features suggestive of IBD, refer for specialized opinion, right? So then what is the secondary assessment? One of the most important investigations in patients with chronic diarrhea is colonoileoscopy with biopsy series. I have highlighted ileoscopy here because a significant percentage of patients in some studies, in some series up to 18% of patients with chronic diarrhea have normal colon with ileal abnormalities. So therefore ileal intubation and terminal ileal intubation is very important in colonoscopy. And also even when the ileum and the colon are normal, taking a biopsy series, ileum, right colon, left colon are very important. And I would like to draw your attention to this study published recently in Sri Lanka Journal of Surgery. Now it has been conducted in one of the very premier hospitals of Colombo. And let's see the conclusion. Now it has several methodological errors. However, having said that, even if it is 50% true, the conclusion is very alarming. The quality of LGIE with regard to all the aspects fall below the expected standards. Majority of the failures are due to lack of awareness and training rather than lack of resources. So it's the responsibility of the referring physician also to refer these patients to a properly trained, qualified colonoscopist. And then, now as I explained to you, microscopic colitis, chronic diarrhea with normal mucosa on colonoscopy, some patients can have ileal lesions with normal colonoscopy. And then cross-sectional imaging is also an important component in evaluation, right? Chronic pancreatitis, MRI pancreas and MRCP. And MRCP with secretin is even more sensitive to diagnose subtle pancreatic dysfunction. And small intestinal pathologies can be diagnosed with CT and MR enterograms. And then extraluminal pathologies and structural abnormalities also need cross-sectional imaging. And upper GI and endoscopy and duodenal biopsies, celiac and tropical screw, and then celiac serology. I have seen some people requesting this. However, this anti-endomysial and anti-tissue transglutaminase antibody have reduced sensitivity in settings like ours where prevalence is low. So be careful. And also celiac disease is not a common disease, at least for the available evidence as at now in Sri Lanka. So if IgA deficiency is present, then IgG anti-endomysial antibody and IgG TTG has to be done. So then video capsule endoscopy, this is also a relatively minimally invasive procedure. So however, it should be used only when upper and lower GI endoscopy and CT MRI enterogram are negative, and we have to make sure that there is no intestinal obstruction before doing a video capsule endoscopy. Otherwise capsule capsule can give rise to retained capsule. It's a surgical emergency if that happens. So therefore, before doing a video capsule endoscopy, these things should have been performed. And also it is useful to further evaluate small bowel pathologies detected in CT or MR enterogram. And then enteroscopy. Enteroscopy has a very limited role in evaluation of chronic diarrhea. It is recommended for targeted lesions identified by the video capsule endoscopy or CT or MR enterogram. And endoscopic ultrasonography is useful in detecting early changes of chronic pancreatitis, right? So the next few conditions I will discuss. Now these may be common conditions, however the tests which are required are kind of not very frequently available. Bile acid induced diarrhea, and 1/3 of patients labeled as IBS have bile acid malabsorption. The diagnostic test is 75 selenium homocholic acid taurine. It is not available in Sri Lanka. What we do is give a therapeutic trial with bile acid sequestrant, cholestyramine, right? And then small intestinal bacterial overgrowth. Breath tests are not sensitive and specific in in the diagnosis of a small intestinal overgrowth. What we do is give a therapeutic trial of cyclical antibiotics. And fat malabsorption, especially due to pancreatic enzyme insufficiency, the fecal human elastase 1 is the test of choice. And lactose intolerance, lactose breath test can be used, and genetic tests also can be used to see whether the specific genetic mutations is there in patients but cannot perform during day-to-day practice. The more pragmatic approach is withdrawal of lactose from diet as a therapeutic trial. And then the other condition for chronic diarrhea is rapid intestinal transit. The post-vagotomy, especially after upper GI surgery, patient can have rapid intestinal transit, and hyperthyroidism, diabetes, autonomic neuropathy are some of the causes. And also there is there is primary functional diarrhea. The definitive diagnostic test is high resolution small intestinal and colonic manometry. And fecal incontinence, you don't need sophisticated test to diagnose fecal incontinence. Just a simple digital rectal examination would find the lax anal sphincter. However, if you plan surgical intervention for sphincter laxity, anorectal manometry and endoanal ultrasonography is mandatory. So you should not be doing surgery. You should not refer patients simply based on digital rectal examination findings for surgery if the patient has fecal incontinence. And rare causes, VIPoma, serum VIP levels should be done during an episode of diarrhea. Otherwise, it can be false negative. And gastrinoma, the diagnostic test is serum gastrin levels. It can be high in pernicious anemia, atrophic gastritis, and in patients who are on PPI. And also it can be mildly or elevated in patients with diabetes, renal impairment and rheumatoid arthritis as well. So therefore, now you have to interpret these results carefully. And neuroendocrine tumors, commonly the midgut carcinoids, they present with diarrhea, especially by the time they have diarrhea, most of these midgut carcinoids have hepatic metastasis also, and also they will have full-blown malignant features like weight loss, loss of appetite and other features of carcinoid syndrome. The definitive diagnostic biochemical test is urinary 24-hour urinary 5-hydroxy-indole acetic acid. So take-home messages, detailed history and thorough examination are the most useful initial steps. Diarrhea is not a disease. Most of the time it's a symptom of another disease. There is no single diagnostic test. Investigation should be guided by the clinical evaluation. Diagnostic approach vary depending on the likelihood of a specific diagnosis. Functional disorders should be positively diagnosed and unnecessary investigation should be avoided. Early lower GI endoscopy is indicated when initial assessment is suggestive of a colorectal malignancy. Seek specialized opinion when there are severe, persistent or atypical symptoms and signs, alarming symptoms and features of inflammatory bowel disease.
Thank you, Hasita. Any questions from the physical audience? One from the virtual audience. How to interpret stool full report and differentiate osmotic and secretory diarrhea?
Well, you can do stool for reducing substances like fructose and lactase deficiencies. It will be positive for stool reducing substances. And what is it? Osmotic and secretory. Yeah. So then osmotic diarrhea, there will be osmotically active particle in the stool full report, and most of the time it will be a fructose and lactase disaccharidase deficiency, which will give rise to osmotic diarrhea.
Again, the place of stool osmolality, I think osmolar gap in chronic diarrhea.
Yes, it's a kind of a very hi-fi thing. I didn't want to touch it because we don't do in the practical setting. So it's useful in secretory diarrhea.
The gap will be...
Yeah, an iron gap, stool and iron gap. Yeah.
Any other questions? So in absence of any other questions, thank you very much for that wonderful lecture. And we'll move on to the last presentation for today. It will be by Dr. Sumedha Udumalalagala, is MBBS, MD, ESC, GH, serves as consultant gastroenterologist at Teaching Hospital Kalutara. He's a graduate from University of Peradeniya and got his MD in 2017. He'll be talking on a case-based discussion on assessment of abnormal liver biochemistry. Over to you, Sumedha.
Thank you, sir. And thank you for the CCP for giving this opportunity for us. And this is the third and last lecture in this series. So my task is to talk you through the assessment of abnormal liver biochemistry. And so this is a very huge topic, but I would like, we can talk on hours and days, but I would try my best to make it very short and more informative. Okay. So to achieve this target, so I would briefly outline the liver biochemistry versus the liver function test and the components of liver biochemistry test and the clinical relevance. And always I want to highlight the R factor in interpretation of liver biochemistry test. And then with this background knowledge, I will move to some clinical application. So first of all, what is the liver biochemistry versus liver function test? So when we order a liver function test, what we usually do during the ward rounds, what comes in is actually mixture of liver biochemistry and liver function. So the components of liver biochemistry is alanine aminotransferase or AST, ALT, and the aspartate aminotransferase or AST, alkaline phosphatase, and gamma glutamyl transferase or GGT. But the bilirubin and albumin and the prothrombin type, it comes separately, but bilirubin and albumin, it's the liver function. It shows how well the liver is working. And so I don't know whether you can see, I just put platelet count at the end, which is not very highlighted. I make it like that because the platelet count, some experts and some people still think it also can use as a functional parameter because it is, I think the trainees and everyone know that nowadays this new evolution calculators for liver stiffness, the platelet count plays a big role. So we need something more about this each component. We have to know the basic physiology and few things to accurately interpret a liver biochemistry test in our hand. So I would give few tips and few important things in this each component. So first thing is the total bilirubin. So the bilirubin, I think everyone knows, it's a byproduct of the breakdown of heme, and it comes unconjugated and conjugated form. And so this unconjugated hyperbilirubinemia, which occurs when there's a hemolysis or impaired conjugation. And conjugated hyperbilirubinemia occurs when there's a liver parenchymal disease or a biliary obstruction. And one other thing I just missed to highlight here, that when the bilirubin is coming to the circulation, the half-life is usually 2 weeks. And the albumin, so this is only produced by the liver, and it's a marker of the synthetic function of the liver, but there are some pitfalls because low albumin does not always reflect the impaired hepatic synthetic function. As we highlighted before, it is a negative inflammatory marker. So it goes down with sepsis, systemic inflammatory disorders, and when it losing from gut or the kidneys in nephrotic syndrome or malabsorption, it also goes slow. Then prothrombin time, we have to order it separately. It measures the activity of vitamin K dependent coagulated factors in the liver, factor 2, 5, 7, 9, and 10. And then we go to the biochemical components, the alkaline phosphatase. So it is produced mainly in the biliary epithelium, and not only the liver, it also comes from non-hepatic sources. We have to memorize that it comes from bone, placenta, intestine, and kidneys. And also we have new electrophoresis methods to identify each subfraction of alkaline phosphatase. Though we don't have here, I think, but we have in the resource-rich settings, we have these facilities. Then GGT, and it's mainly present in the liver, but it also present in kidney, intestine, pancreas, and prostate as well. But we have to know that gamma glutamyl transferase is not present in bone. Okay, and it has a low specificity for liver disease, but it helps to exclude bone diseases. And then the ALT and AST. So ALT is more liver specific than AST because it's mainly located in the cytoplasm of hepatocytes. The ALT activity is more than 300 times in the liver than other areas, and its plasma half-life is usually 47 hours, 48 hours, let's say 2 days. And when there's a damage, it usually takes within 48 hours it released into the circulation. And the AST, it is less liver specific, and it is mainly distributed in the mitochondria and zone 3 of the liver, and its plasma half-life is only 18 hours. And also this ALT-AST ratio, if we can calculate it properly, it will give you a clues to the etiology, what's happening there. And the pattern of liver biochemistry test elevation, the R factor or the R ratio. This is very, very important. This is a new way of looking at the liver biochemistry. This is new way of looking and classifying what type of liver injury is going on. So we don't need to memorize these calculations. It is freely available in our smartphones and the MedCalc app. So we can just put in the numbers, then they will give us the R ratio. So the importance is that depending on the R ratio, the R value, there's a separate set of DDs, and there's a separate way of organizing the next investigation. So if the R factor is more than 5, then it is a hepatocellular injury. So hepatocellular injury usually happens in acute viral hepatitis, ischemic liver injury, autoimmune hepatitis, and in Wilson's disease and the drug-related conditions, especially isoniazid, antiepileptics, macrolides, and nitrofurantoin. And inhaled anesthetics like halothane, NSAIDs, and green tea extracts also cause hepatocellular type of injury. Then the cholestatic pattern, previously we used to tell that is jaundice or obstructive jaundice, and when the R factor is less than 2, then it can be a intrahepatic or extrahepatic cholestasis, and also it will happen in sepsis and total parenteral nutrition, heart failure, and the medication, specifically coamoxiclav, trimethoprim, and azathioprine. The mixed picture, when the R factor between 2 and 5, then we classify it as mixed. So this can happen in viral hepatitis, autoimmune hepatitis, and certain identified medication, especially phenytoin, carbamazepine, and lamotrigine. So having these tips and the clinical relevance in back of our mind, so then I will move to few clinical scenarios and try to apply this. So, and as well as in any medical case or any medical disease, before we go to interpret a liver biochemistry test, we should have a good history and examination and all the relevant and available other tests with us, because it will give you a clue to what's happening. And if you see this history, it's a 78 years old man presented with 1 day history of epigastric discomfort, nausea, and vomiting. His past medical history comprised of diabetes, hypertension, and dilated cardiomyopathy with ejection fraction of 30%, with stage 3 diastolic dysfunction. On examination, BP was 96/50, heart rate 98, respiratory rate 26, and saturation 94. And clinically, he is in heart failure with bibasal crepitations and elevated JBP. by looking this history, we know what's coming next. So this is the liver biochemistry test. It shows very high elevation of transaminases. The AST is 5000, ALT is 3000. So very high is a massive elevation with the elevation of bilirubin as well. Okay, so additionally that, and so this is ischemic hepatitis. So then we can move into our next. The magnitude of transaminase elevation, it is very important in several ways. One thing is that depending on the level of elevation, there's a separate set of differential diagnosis. So the borderline or the mild elevation up to 5 times, 3 to 5 times, they usually we see in non-alcoholic steatohepatitis, drug-induced liver diseases, chronic hepatitis B and C infection, and hereditary hemochromatosis. In the moderate elevations like 5 to 15 times, usually happens is DILI, the drug-induced liver injury, and alcoholic hepatitis, and the autoimmune hepatitis as well. The massive elevation like more than 15 times or more than 10,000, it usually happens is ischemic liver injury, paracetamol poisoning, viral hepatitis, and also we can see in autoimmune hepatitis and drug-induced liver disease. But if it is having more than 10,000, like the very massive elevation, then we have to think broadly, whether it is actually liver injury, paracetamol poisoning, or whether it is coming from rhabdomyolysis or heat stroke. Then move to case number 2. So this is a 21-year-old previously healthy female presented with 1 month history of worsening jaundice, intermittent nausea, fatigue, loss of appetite, and unintentional weight loss. And she didn't have a significant medical history, and she's on examination, she's icteric, pale, no stigmata of liver disease, and she has hepatomegaly, non-tender, smooth with regular margins. So her liver biochemistry case, on admission during the first week of illness, it came as AST-ALT elevation around 100, 120 with a slight elevation of total bilirubin and normal ALP. And in third week of the disease, and we noticed that there's a change in her albumin globulin ratio and more elevation in AST-ALT and bilirubins and ALP. So if you calculate the R factor here, it is come under between 2 and 5. It's a mixed picture. So we know what are the differential diagnoses we have to think of, whether it's a chronic hepatitis B, hepatitis C, or whether it's a DILI, or whether it's autoimmune hepatitis. So the history gives us some clue, and then the biochemistry gives us some clue. Then we have to have some additional test. So we request INR, hepatitis serology, and ANA and the ferritin. So here we see the very high ANA, anti-nucleic antibodies, more than 1 in 160. So, but actually when we see a biochemistry like this, when it is, our practice is to order a full liver screen, which should include actually the viral hepatitis screen and the autoimmune panel with the ANA, ASMA, and LKM, and the AMA, and also the ferritin levels. But we don't have that luxury here. So at least if we can have the ANA levels, it is better. So here we have the ANA levels is more than 1 in 160. If it is more than 1 in 80, it is highly positive. And so this is in this correct clinical context, we have to diagnose autoimmune hepatitis in this patient, and we have to order a liver biopsy to confirm it. Okay, so when we come to the autoimmune liver diseases, we have to know a few things. The common things are autoimmune hepatitis, type 1 or type 2, then the primary biliary cholangitis. We don't call it cirrhosis anymore, we just call primary biliary cholangitis. Then autoimmune hepatitis with overlap. It can be overlap with autoimmune primary biliary cirrhosis or PSC. Then the PSC per se and the IgG4 related disease spectrum diseases. So they have different characteristic. The liver injury is different, and the autoimmune panel is different, and the then the histology also different. So AIH, we can see hepatocellular or mixed liver injury, and with positive ANA, AAA, anti-actin antibodies, and PNCA, anti-smooth muscle antibodies, and anti-liver kidney microsomal antibody 1 and 2, and ALC antibodies and anti-soluble liver pancreas antigens. And also they are negative for viral markers, and they have elevated IgG levels with characteristic histology with interface hepatitis, lobular inflammation. And so each component have is different scoring system to diagnose autoimmune hepatitis. So I am not going to touch about that because it is beyond the scope of this lecture. Then the primary biliary cirrhosis, it is mainly cholestatic liver injury. They will have ANA positive and the anti-mitochondrial antibody positive, and they will have a negative MRCP, and they will have elevated IgM, and histology will show bile duct injury. And then things become a little blurry when it comes to the overlap area. So AIH with overlap with PBCO, AIH overlap with PSC, they will have mixed or hepatocellular injury liver pattern, and they might have ANA, SMA or AMA positivity depending on the disease, and they will have negative viral markers as well as MRCP might be normal if it is PBC overlap, but if it's a PSC overlap, there might be some MRCP changes showing some obstruction. And their histology, depending on the more marked histological part, it will change. If it is AIH histology, they will show interface hepatitis and liver, the lobular damage. If it is PBC histology, then it will show granuloma and duct injury. And the PSC, it is mainly a cholestatic liver injury, which they will usually have a PNCA positive in some patients, and usually they don't have ANA, ASMA or AMA positivity. And the MRCP would be a characteristic, but MRCP would be negative if it is a small duct PSC. And they will have characteristic histological signs like this onion shell appearance. Then the one of interesting area, the IgG spectrum disease. It is mainly a cholestatic liver injury, and with a sclerosing cholangitis, 50% of this patient will have IgG elevation, but not all. And the MRCP will show strictures, pancreatic abnormalities, and IgG positive plasma cells in the histology. It's a diagnosis, the most helpful gold standard. So having said that, we move to the case number 3. So it is a 43-year-old previously healthy man presented to the clinic when his liver profile was found to be deranged during a routine medical screening. Denies unsafe alcohol consumption. So history says what's the most probable diagnosis here. So past medical history is unremarkable. He has a high BMI, is 28, he comes to obese when it comes to the South Asian population, and he is not icteric, then he has a very smooth hepatomegaly. So the liver biochemistry shows a slight elevation of AST, the borderline elevation of AST and ALT, and the normal bilirubin, and the LP and gamma GT is normal. So we know what is this. This is metabolic dysfunction associated with steatotic liver disease. But before we go there, we have to request for some additional test. So what we have to look whether it's hepatitis B and C serology negative. Yes, it is negative. Then we ask for ANA, it become positive. Then the ferritin is high, 256. Transferrin saturation is normal, 28. Fasting blood sugar likely in the impaired range, and hepatitis HbA1c also in the impaired. IgG levels normal, lipid profile high triglycerides. So he has more symptoms, more findings to suggest steatotic liver disease or NAFL, non-alcoholic fatty liver disease, but there are some red flags. ANA is positive and the ferritin is high. How common this is in non-alcoholic fatty liver disease? Yes, ANA, ASMA, low titers positive in up to 30% of patients. And in general population, ANA might be positive up to 10 to 15%. And in non-alcoholic fatty liver, the ferritin, it's also very high, Sometimes it can go more than this, but the transferrin saturation should be normal. And one important tips is that just having non-alcoholic fatty liver disease will not cause increase in bilirubin. Bilirubin should be normal unless patient has underlying Cox-Gilbert syndrome. And definitely they will have metabolic risk factors. And the case number 4, a 53-year-old man was transferred from another hospital with progressive jaundice and lower extremity edema that has lasted for 4 weeks. And he has a long history of unsafe alcohol use, and last drink was 3 weeks prior to the admission. He has type 2 diabetes mellitus, and there's no proper follow-up for that. And he is febrile with heart rate, his blood pressure was 118/82 and respiratory rate 16, pulse rate 97. And he is icteric in sclera and the skin, and he has tender hepatomegaly and lower limb pitting edema. So the biochemistry came as high AST. It's not very high, but it's in the 5 to 15 range, and ALT high, and bilirubin is with compared to the AST ALT, the bilirubin is slightly more elevated. And so the history and the biochemistry all suggest the patient is having alcoholic associated hepatitis. So what are the clinical characteristics of this? The patient should have unsafe alcohol use. I know this is very difficult to dig out most of the time, because they will say, no, I am not drinking alcohol recently. But if the patient drinking alcohol up to 8 weeks back, it is still possible. Then they will have a very significant elevation of bilirubin levels and moderate elevation of aminotransferases. It never goes more than 500, and the AST to ALT ratio previously says it is more than 2. Now it's considered, if the ratio is more than 1.5, it is suggestive. And also we see several occasions when the patient coming with alcoholic, very unsafe alcohol history and found to have 1000 bilirubin, the AST ALT is over 1000, sometimes they label it as just alcoholic hepatitis. So never do that. There should be something else as well. So case number 5. So this is something we all have to be aware of. This is a 26 years old unmarried lady, POI of 26 weeks. She has never come to the clinic following the first booking, and admitted from the clinic due to identification of IUGR and clinical jaundice. She also gave a fast medical history of an episode of jaundice at the age of 16 years. No proper history available other than that. And she also denied any over-the-counter medications or recent antibiotics. On examination, she was icteric, no features of chronic liver disease, and her UFR was normal, negative for albumin, and there's no proteinuria, and her BP was normal. So what's happening there? Then urgently we got the liver biochemistry. So it says very low albumin, 2.2, and high globulin, AST 87 and ALT 130. Total bilirubin is very high, 143, direct bilirubin 104, ALP is elevated. So this referral came in the night after 6 p.m. So this is the usually things I think happen all the time. And then fortunately we were able to arrange one of our senior registrar colleague in the radiology department to do a ultrasound. It shows slightly hyper-echogenicity of liver, suggestive for liver parenchymal changes. Spleen is not enlarged. GB is contracted, and sonographic Murphy is sign positive. Things getting complicated. And INR was 1.62. So what was the differential diagnosis here? So it would be acute fatty liver pregnancy, whether it's a HELP, whether it's a viral hepatitis per se, or previously undiagnosed chronic liver cell disease, or the intrahepatic cholestasis of pregnancy, which is very, very unlikely here. So this lady, the presentation fulfilled the Swanson criteria, which is used to diagnose acute fatty liver pregnancy, which is a emergency. And so we diagnosed acute fatty liver pregnancy here, and we are opted to LSCS next day morning as early as possible. But however, the fetal distress noticed in the night, and She underwent emergency LSCS during the night. The POI was 26 weeks. And then we follow up the lady because the baby was admitted to PBU and the patient is in the hospital. So we follow up. Then 2 weeks back, this is her liver functions. Protein is still albumin low, but it's getting better. And AST, ALT almost normalized. And the bilirubin is now almost normalized. So this was acute fatty liver pregnancy. The thing is that we have to, it's a clinical emergency and you have to diagnose it with the correct clinical context. So you will not have time to ask for hepatitis B, hepatitis C and those fancy tests around, but you have to take a clinical decision. And when it comes to the liver biochemistry changes during the pregnancy and the liver biochemistry changes unique to pregnancy, it is not always straightforward, always this is a gray area. So we have to make ourselves familiar with acute fatty liver pregnancy, HELP syndrome, intrahepatic cholestasis of pregnancy, and the hyperemesis gravidarum. These are the 4 unique liver biochemistry liver problems happen during the pregnancy. So the timing, usually acute fatty liver pregnancy happens usually the end of the 2nd trimester or the 3rd trimester. AST, ALT levels could be elevated, and the ALP levels, the normal or slight elevations, because up to 4 times it can be normal during the pregnancy. And the bilirubin is high, and INR usually elevated. Serum bile acids, there's no role in diagnosis serum bile acid in AFLP. Then the problem is that it's an emergency, they can quickly go into acute liver failure, hepatic encephalopathy, AKI and bleeding, and it can cause a very high mortality sometimes. So we have to act early, so we have to make clinical judgment. Then the HELP, it usually occurs during after 20 weeks of pregnancy. Then the AST, ALT levels elevated as the name implies, and the ALP normal, or it may be slightly elevated, will be a normal during the pregnancy. Then the bilirubin, they usually have high indirect bilirubin because of the hemolysis. And INR, it can be high because they can go into DIC sometimes. And they usually complain of abdominal pain, nausea, vomiting, and also they will have low platelet as a component of the HELP. Then the intrahepatic cholestasis of pregnancy, previously we used to call this benign, but now we don't anymore, we call it benign. And so it happens during the 2nd or 3rd trimester, and AST, ALT most of the time normal or very slight elevation sometimes we can observe, and the ALP usually elevated, it is more than 4 times. Up to 4 times it may be normal, but during intrahepatic cholestasis of pregnancy it will be more than that. And the bilirubin, it can be normal or it can be slightly elevated, can go up to 5 milligram per deciliter. And the INR might be elevated, it's just because of the lack of vitamin K or the vitamin K deficiency or cholestasis, but not due to a synthesis problem. And the serum bile acids, this is the only place where we use the bile acid and it will be positive, high. And the most important thing is the history, and the people will definitely show that itching and the pruritus, especially in the palms and sores, which is more in the night. That is the clinical history. And the hyperemesis gravidarum, it usually happens during the 1st trimester or early 2nd trimester, and AST/ALTs can go up, usually less than 300, and the bilirubin also can be gone up slight elevation. And in supportive evidence, they might have some features of hypothyroidism clinically and biochemically. So case number 6, and this is a very straightforward. It's an 83 years old male presented with a painless progressive jaundice for 3 weeks. It was associated with pruritus and dark urine. There was a loss of appetite and unintentional weight loss. So, and he has a background history of type 2 diabetes, hypertension, and ischemic heart disease. So he's deeply icteric and evidence of excoriation due to scratching, and on examination, soft rounded mass in the right upper quadrant. So the history implies, so there are something sinister going in. So the patient had a very cholestatic picture with a total bilirubin of very high, with a very high ALP and gamma GT. So this is the R values less than 2, so it's cholestatic, and this is cholestatic liver injury due to extrahepatic biliary obstruction due to pancreatic head malignancy. Okay. And then case number 7, this is a also a very interesting history. It's a 60 years old lady with a long-standing type 2 diabetes mellitus and arthritis, presented with pruritus and progressive jaundice, vague abdominal pain and lymphedema. She only taken prescribed medications for her type 2 diabetes mellitus, and also she denies any over-the-counter medications. But after repeated digging, only she revealed that she was taking some native medications for her arthritis for last 8 years duration. And she also 2 days back also she was taking the medication. On clinical examination, she was deeply icteric, scratch marks, mild lower limb pitting edema, and palpable hepatomegaly with non-tender firm liver. And also when she comes, she brought the following blood test and ultrasound report with her. So total protein was 7.3, it's normal, and AST is high, 345 with ALT 457, and the total bilirubin is 12.9, so very high. Direct bilirubin is 10.2, and her ALP is 357, so her R value is between 2 to 5, so mixed injury. And then her ESR is 15, full blood count is normal, and she also came with hepatitis A and B serology, which was negative, and her ANA is positive, 1 in 80. And ultrasound abdomen is a hepatomegaly, increased echo texture with smooth margins, no splenomegaly, no evidence of portal hypertension, distended gallbladder with dilated CBD 8 millimeter, or then it queries obstruction at the distal CBD. So it's concluded as fatty liver grade 3, distal CBD obstruction suggests CCT abdomen for further evaluation. For when we have these things in our hand, we think, okay, there is some obstruction going on, there is an obstructive jaundice. So we thought initially is extrahepatic biliary obstruction. It may be a choledocholitis, cholangiocarcinoma, ampullary carcinoma. And so we requested a CCT abdomen with 4 phase and CA19-9 levels and alpha fetoprotein levels. So came the CCT abdomen 4 phase, no CBD or intrahepatic duct dilatation, CBD at upper limit of normal, no liver lesions. So CBD is usually 7 millimeters, and that's the upper limit of normal. Then it ruled out the biliary obstruction. So we have to revise our diagnosis, whether it is intrahepatic cholestatic liver injury. What is it? It will be DILI, because patient is on some sort of a native medication. So what we did, we didn't do any further invasive test or anything else. We just observed the patient for 2 weeks. So what happens after 2 weeks? The total protein still seems reasonable. AST was showing marked improvement, is 88 and ALT 142, and bilirubin of almost half, and ALP was coming down. So we think, so it is DILI, drug-induced liver disease due to this native medication. And we also keep her with close under observation with 2 weekly LFTs and see if they want to revise our DDs again. So this should be the last one. This is a 33 years old male presented with the complaints of intermittent dry cough, weight loss and abdominal discomfort for 1 year. He reported an unintentional weight loss of over 10 months, and his prior evaluation included a CCT of the abdomen, which shows hepatosplenomegaly and multiple lymph nodes in peripancreatic, para-aortic and pericaval region, no biliary obstruction, and he is already been treated 8 months with ATT in the basis of granulomas in the FNAC of his abdominal lymph nodes with no clinical response. On examination, patient is cachectic, pale, not icteric, no peripheral lymph nodes, mild nodular hepatomegaly, and spleen tip was palpable. So he shows total protein of 6.3 with albumin globulin reversal, AST is 67, ALT 47, bilirubin is slightly elevated 1.8, and marked elevation of ALP and gamma GT. So what shows this? It shows a infiltrative liver disease. So the working diagnosis here is granulomatous hepatitis. So the differential diagnosis is whether it's TB, tuberculosis, but it's already been treated, whether it's sarcoidosis, it's possible, and whether it's a drug-induced granulomatous disease like allopurinol, carbamazepine, or methyl-dopa. There's no history of taking any of medication there, and whether sometimes, especially all people, they will have granulomatous hepatitis due to temporal arteritis as well. But here we thought the the diagnosis was sarcoidosis. So I think that's the end of the these clinical scenarios. So thank you.
Yeah, just one question on the virtual audience. Is there any difference of AST and ALT ratio in leptospirosis versus other hepatitis?
There was they say is usually the AST-ALT ratio in the leptospirosis is usually more ASTs more than the ALT. But it is sometimes it is true, but it's not always. Sometimes it is not a very hard and fast thing.
Right. Thank you very much, Sumedh, for that interesting presentation of clinical scenarios. Before we end, we have the certificate of appreciation. Can Hasita also join us on the stage to receive the certificates?